Good morning, everyone. My name is Aditi Patel, and I am one of the cardiology fellows. I am introducing Cardiology Grand Rounds. I have the pleasure of introducing Dr. Robert Hoyt, and he'll be giving his talk on artificial intelligence and cardiology, the good, the bad, and a few surprises. Just for your awareness, there is a code for continuing medical education credit. Please text 31379 to that phone number. With that, I will be introducing Dr. Hoyt. He completed his internal medicine residency at MCV/VCU in 1974. He served 3 years in the U.S. Army and entered private practice for 15 years in Virginia. Following that, he returned to active duty and completed 17 years in the U.S. Navy and retired at the rank of captain. In the last several years of active duty, he conducted research at the Navy Aerospace Medical Research Laboratory and the Robert E. Mitchell Center for Prisoner of War Studies, located in Pensacola, Florida. He retired from active duty in 2009. While on active duty, he taught health informatics at the University of West Florida for 10 years. He is the editor and author of Health Informatics Practical Guide, which is in its 8th edition. In 2014, he became board certified in clinical informatics, and in 2016, he became a fellow of the American Medical Informatics Association. Since 2018, he has primarily focused his attention on data science and has led to the creation of 3 textbooks: Introduction of Biomedical Data Science, Data Preparation and Exploration, and No-Code Data Science. Dr. Hoyt is the honorary president of the Medical Intelligence Society, contributing monthly to the Data Science Tip of the Month virtual meetings. He's on the board and faculty of the American Board of Artificial Intelligence in Medicine Board Review course. Additionally, he is a reviewer for multiple medical journals, including the newest Intelligence-Based Medicine Journal. Thank you, Dr. Hoyt, for joining us. We really look forward to your talk.
Thank you, Dr. Patel, and thank you for that kind introduction and invitation to speak. So today, what I plan to do is present some background about AI, so hopefully it'll be a more level playing field for the people that are listening. We'll talk about predictive AI versus generative AI with use cases of both, and we'll list some interesting applications of AI in cardiology along with a few surprises. And then lastly, we'll kind of list some of the challenges that we face with AI and large language models. So I'd say fasten your seatbelts, put your tray in the upright position, and get ready for takeoff. So I have no conflicts of interest to report. I did share the slide deck, and the footnotes are hyperlinked. So I think one point that you already know is that, the genie is out of the bottle or the train has left the station. It's really hard to hide from AI these days, but the challenge is to make sense out of it. So let's start with history and introduction. I think it's important to have some historical context because it's not been a very linear process, if you will. I'm going to say that it began with Alan Turing simply because he had the wisdom to see that machines and computers would augment what we do and would be helpful. The term artificial intelligence was coined in 1956 by John McCarthy, and a year later, the simple perceptron was introduced, which was really the first of the artificial neural networks. Ironically, one of his own colleagues said, well, that'll never work. And that began one of the first AI winters where nothing happened. The next thing was 1972, the Mycin Project by Dr. Shortlift, who's still out there, and some of you may know. But it was simply rules engines, and they had very poor technological support at that time, so it really never got off the ground. So fast forward to 1989, when early convolutional neural networks could analyze images, but they really didn't go very far either until GPUs, graphics processing units, were developed from the gaming industry. And suddenly now that augmented and helped tremendously what we were able to do. 97, you all probably heard about Deep Blue. IBM was in big time with major computing. But again, another gap between Deep Blue and IBM Watson. I think it's interesting that Watson was not very successful, and IBM sort of got behind the eight ball and is only now recovering from Watson. So 2016, you may have seen the movie on Netflix, AlphaGo, where they're able to beat the world's Go champion. This was actually quite a challenge because of the complexity of the game. But if you note the movie, it took them 2 years to train the model. They used deep reinforcement learning, by the way. Next year, an improvement on that. And then in 2017, there was an article that was very important entitled Intention is All You Need. This is when Google DeepMind came up with transformers with attention, which basically revolutionized natural language processing. So it would predict the next word in a sentence, but it could predict a whole sentence. It could look at an entire paragraph. It was much faster, much more accurate than anything we had before. So that was a sentinel event. AlphaFold in 2020, we're now up to AlphaFold 3. 2022, as you know, just 2 years ago, ChatGPT 3.5, which began a major step with generative AI. And then in 2024, it's just more large language models. Now we're seeing multimodal that will analyze or produce audio, video, you name it. And it's unknown whether we'll see GPT-5 this year or early next year. So I've broken these into different time periods. On the far right, I put generative AI as a new era. That's my designation. Nobody else is saying that. It's really part of modern deep learning, but that seems to be what we're discussing these days. So most people would say that machine learning, deep learning, and generative AI all fall within artificial intelligence. All of them have varying definitions, but basically the simplest for AI is any technique which enables computers to mimic human behavior. And machine learning is largely about using algorithms to predict something. Deep learning is using complex neural networks with more than one hidden layer. And generative AI, I talk about large language models, but the point is there are other methodologies like diffusion models and GAN and other things, but we're going to focus on the most common, which is large language models. Where did we get to where we are today? Well, there's at least three different moving or driving forces. One is better methodologies with transformers and convolutional neural network. Another is better storage. So many things are cloud-based. And then last, I mentioned the GPUs that we largely now get from NVIDIA. I will say that we need to be cognizant of the fact that the AMA does not particularly like the term artificial intelligence. They like augmented intelligence to indicate that it's there to simply to assist us. And I can't disagree with that, but I think there's no question that we're going to have to rewrite some of the definitions as well as the benchmarks. We've already passed the Turing test. So, we have to say, are calculators an example of augmented intelligence? When we go back to expert systems in the 70s, is that really AI? I don't think so. So I think all of that's going to change in essence. Now, just to explain narrow versus general artificial intelligence, pretty much everything that you've seen recently is narrow AI. It's not general artificial intelligence. Narrow is just a simple task and it can't do anything else. For instance, if you train a model to pick up pulmonary nodules, it can't do much of anything else. When we achieve artificial general intelligence, whenever that is, it will be more autonomous, it'll be multimodal, it can reason and so forth. And the jury's out about when we will see it. I've seen quotations of 2 years and up to 30 years. Now, I included this diagram because you're all familiar with the data to wisdom pyramid, I'm assuming, but if you interject intelligence, what that would mean to me is that if nothing else, it would serve as a reminder. You're trying to make a decision, it's clinical decision support, and the intelligence would say, have you considered this? It expands your differential diagnosis and it's reviewed the literature and said there's a new development out of the Mayo Clinic or wherever. So I think and obviously initially my thought was, well, it's got to be embedded in the electronic health record, and that would be win-win, but not so fast because there are problems with the electronic health record, note bloat, uh, erroneous information, and so forth. But okay, I know this slide probably causes nausea, but machine learning is largely about predictive analytics. If you look in the upper right, supervised learning, what that means is you have data and you have the output that you're interested in. Let's say you're interested in looking at reducing hospital readmissions. You have a spreadsheet with 1,000, you've collected data. The last column is readmitted, yes or no. And if it's a categorical data, that's classification. If you're trying to predict something numerical like length of stay or charges, that's numerical, therefore it's regression. So a lot of machine learning is predictive analytics. If you go to the bottom, reinforcement learning, I've already mentioned that came from the gaming industry and is all about penalties and reward. If you think about the game Pac-Man, that's a good example of a game with rewards and penalties where it goes around the board and learns. And the upper left is interesting. That's not generally discussed, but very important. Unsupervised learning means you have data. You have no output like readmitted, not readmitted. You've got just data. And how this came in handy was with genomic data. They wanted to make sense out of the genotypical and phenotypical information. So it finds clusters or groups, and that's very valuable, and it's under leveraged, I might comment. And I'm not going to get into technology, don't worry, but deep learning is neural networks with multiple hidden layers. Computer vision, again, is primarily convolutional neural networks. That was what we used early on. But now large language models are multimodal. Generative AI is transformer-based, I mentioned. Text to image is several different technologies. But one point to emphasize is that computers do not recognize words or images. They have to be converted or encoded first into numbers and then represented using vectors, which the term is embedded. So in the lower part of the screen, you see ones and zeros. The machine learning learns these patterns and creates a model. This should come as no surprise. If you look on the right, this is worldwide data. By 2025, it's thought that we're going to have this many zettabytes, 100 and I think it says 81, and 1 zettabyte is 1 trillion gigabytes. So the medical information is also doubling. PubMed doubles every 5 years. How are we going to manage that? We hope that the goal will be, and this is kind of a summary, if you look on the left, that obviously we'd like to see personalized medicine, but we have all these other areas that would gain or benefit from AI. So you would basically take input from all the different areas, including real world data from wearables, let's say, pump it all into electronic health records or a data lake, use multiple modalities of AI. If you look at the lower semi-supervised, supervised, and whatnot, and this would benefit patients. Now, a word about predictive versus generative AI, which is not much is said about it, but it is important to understand. Roughly 15 years ago, when they started with convolutional neural networks primarily, they had to train a model with, say, 10,000 chest x-rays in order to identify abnormalities. And the same would be that they would have to train extensively. Along comes generative AI with transformers, and it's trained so extensively on billions of parameters, which is weights in the model, basically. And again, I don't want to get into technology, but basically it does it without the additional training, so-called zero-shot training. In 2023 was referred as the year of text to anything. So we're in the generative age. Why? Because they're everywhere. They're open source, if you like. They can be tiny, medium, large. They're multimodal. Many are free. I have to say this week I installed one on my laptop. I was very proud of that. So I have it, it doesn't require, you're not paying for an API or anything else. So again, it's no surprise where generative AI is popular. Now, if you look though at the predictive, remember I mentioned that predictive AI has been around about 15 years, particularly with radiology. And even though it did well, relatively speaking, it's not really been adopted all that much. It seems to function at about the level of a junior faculty much of the time. But again, the adoption by radiology has been low, I think for multiple reasons, fear of job loss, lack of good proof and studies. So even though it's out there, it has potential. It's not had widespread adoption. All right, predictive AI, I want to mention one thing that I think is interesting is that it can do facial recognition. And this is a study from this summer where they were able to diagnose very accurately Marfan syndrome. And I include two other studies where this has been used with rare disorders, particularly in children. So no longer are children going to have to wait 2 years to get a diagnosis from a rare disorder. When you compare facial features and other features of digits and whatnot, plus phenotypical information, you can come to an answer much more quickly. So I'm going to talk about large language models for a minute. I'm going to say, though, that really you could spend a lot more time. In fact, I'm conducting a workshop Monday in Orlando at an AI conference where I'll devote a lot more time to it. So I'm going to go over this relatively quickly. There are literally thousands of large language models out there. And surprisingly, even though they've not been trained specifically on medical data, they have in fact looked at abstracts and open source articles from, say, PubMed and whatnot. There are biomedical large language models out there, roughly 15, but are still in beta testing. We don't yet, oddly enough, we don't yet have good evidence that one of the new ones, like say Google Med Gemini, gives you better answers than GPT-4o is just one example. I think we think they will, but it's too early to say that. Now, the large language models are very helpful to assist in coding, programming, in other words. And I frankly do use one model. It's special, customized for data analytics, if you will. And it does give occasional errors, but it's surprisingly good and saves a tremendous amount of time. I would say large language models are least controversial in doing administrative tasks. I'm sure many of you all have created outlines. Maybe some of you have done authorization letters and so forth. I do want to give you a take-home point, and that is, particularly if you're going to be doing administrative things with a language model, you don't need large language models. You're much better off with smaller language models, one that you can put on your own server, as a matter of fact. So it's more private, more secure, more cost effective. The carbon footprint is smaller, and there's loads of them available. So just understand you don't have to have a large language model if you're just doing something for efficiency. Now, many of you are probably familiar with the concept of retrieval augmented generation. What that just simply means is you're going to upload, let's say, clinical practice guidelines, something to make the large language model smarter and more specific, because it has tremendous general information. But let's say you're interested in, some aspect of cardiology, something genetic. It's not going to know that in all odds. So you can upload multiple PDFs, let's say, and it'll be smarter. Now, I do have to emphasize, it doesn't train on these PDFs that you upload. It actually converts the PDF to a vector database so it can simply access it. So it's like going to a library and knowing which shelf something's on. So it trained on the universe, so to speak, but now you're doing fine train. It's not training. I don't want to use that word. you're now given access to specific documents. So in the upper right, I had it trained on one of my textbooks, so now it gives answers based on its general information, plus it'll quote what chapter and whatnot. In the lower part, an article review bot, I created a chat bot that basically was given instructions on how to review an article in machine learning AI with ended up 46 questions it had to review in order to give an answer. And everybody's interested in creating your own chatbot. You can see the hyperlink at the bottom. I put together a YouTube video how to do it. Now, sort of a moment of caution, however. This article is helpful that kind of proves that if you're trying to have a chatbot that answers, say, oncology questions, and you feed it lots of information as RAG to try to make it smarter, it in fact did do better. It was much more accurate, but notice the correct responses of 84%. That's not perfect. And so I want to emphasize that, but at the same time say, be aware there's an incredible amount of money being spent to make RAG work better through a variety of methods I won't get into. So stay tuned. Ambient AI scribes, I know that MCV's looking at several of these. They've been out now for a while. There's multiple companies. The literature, though, is not overwhelming. It's mainly pilot projects, small studies, in other words, not convincing that it saves a whole lot of time. And I'm sure the early adopters have leveraged it and said it's great, and the late adopters have said, I don't need it, and everybody else in between. I'm happy to say that one company, Bridge, is looking at doing something very similar for nurses. But I think the definitive study has not been reported yet on the role of ambient scribes. Just a reminder that with GPT-4o and others, the ability to analyze graphs is surprisingly good. This one I fed an audiogram. All I said is, please analyze. It did a great job. I've done that with pulmonary function test and other things. This is just an example of also the difference between a short prompt and a long prompt. This is a colon biopsy, and it's malignant. And I just said, analyze this image, and the response is on the left. On the right, I said, I gave it clinical context and got a much better answer. So how extensive your prompt is very important. So I'm going to summarize these very succinctly, if I can, and just say large language models show tremendous potential in administrative tasks to expedite and simplify things. Without a doubt, they're very good. Not perfect, but quite good. They score well in standardized medical questions, for instance, the USMLE data bank or question bank. So they have great potential for research in pharmacology. At this point, they are limited with clinical decision support. If for no other reason, they need to be pretty close to perfect. And too many of them looked at retrospective data, not real data, and so forth. And also, they do a great job of expanding your differential diagnosis, but the studies so far suggest that they rarely pick the number one diagnosis correctly. So they do expand on it, however. So let's talk about AI and cardiology. And I'm going to start with two surprises, but let me just say that there are many more surprises. This same era of roughly 5 years ago, for instance, is when they were able to look at retinal images and not only pick up diabetic retinopathy, but also say, oh, we can predict the age and gender and smoking status based on that. And that's because it's one of the few areas you can actually look at arterioles. Also, early study about that same time, they were able to predict race based on the chest X-ray and diabetes, yes or no, based on a chest X-ray. So there were a good number of surprises of how did AI do that. Well, let's just talk about two in cardiology. This came out of the Mayo Clinic. You're probably familiar with this study. This was, again, using a convolutional neural network to look at a ton of EKGs that were trained on people that had atrial fibrillation or who were normal, and they were able to predict future atrial fibrillation on a regular 12-lead, 10-second EKG. So on the surface, the numbers look pretty good, although sensitivity, which is recall, I would say that's so-so or mediocre. But I think to fly in the ointment to me is the precision was low, and that's often not commented on. And another caution is the gray literature, which where you may learn about this, is going to hype it and say, look, this, now we can predict atrial fibrillation from a normal EKG. Well, not so fast. You need to dig deeper and look under the hood because it had a very low prevalence. And with low prevalence, you automatically have a positive predictive value. So I used Bayes' theorem and calculated that it is a positive predictive value of only about 25%. So too many false positives. So they did later look at predicting age and gender from EKG, and that looked a little bit more promising. Do we know how it did it? Nope, that was a surprise. The next study out of the Mayo was to pick up asymptomatic left ventricular dysfunction, which occurs infrequently. So once again, we've got a low prevalence issue. So they paired EKGs and echocardiograms, meaning that if somebody had a low EF, they labeled the EKG low EF, if you will, and that's what they trained on. The threshold here was 35%. So again, sensitivity specificity was better. They didn't report the positive predictive value. I calculated it to be about 31%. So again, a lot of false positives. So a subsequent study, which probably made the gray literature as though they could predict asymptomatic left ventricular dysfunction on routine EKGs, but I pulled the study and saw that there were only 27 subjects. Another study that was interesting that falls in the same category of, wow, how did AI do this? Study out of Japan where they paired EKGs and echoes, and they labeled them based on the training that, for instance, if they had moderate to severe aortic stenosis, the chest X-ray was labeled that. So they trained on 3 hospital systems and tested on the 4th. And they were really bragging on the high area under the curve, so to speak, and suggested that countries that had not enough cardiologists and echoes could use these chest X-rays to screen people that were suspected of having either valvular heart disease or low ejection fraction. But if you look at the table on the right, you see that the positive predictive value was quite low, but again, low prevalence for instance, aortic stenosis. So again, I plugged it into Bayes and the positive predictive value for aortic stenosis was only 20%. So my again, repeat message here is don't trust the gray literature, look at the article, but critically appraise it using data science tools. All right, I want to shift gears. This came out in Circulation. You may have seen it. This was a review of AI, if you will. And what I did is I used these categories as a go-by. I looked at it, but I updated it with some that are actually newer, some articles. This first one, when we talk about multimodal cardiac imaging out of China, was interesting to me because they developed their own system, if you will, that was able to quite, it did very well differentiating ASD, dilated cardiomyopathy, hypertrophic cardiomyopathy, and prior MI with considerable accuracy, if you will. And many of the reviews have suggested that it will help with image acquisition and segmentation. And that what many of the articles, this one out of Toronto, suggests that you could also integrate other clinical features and phenotypical information with the AI. That's a recurrent theme, if you will. And the third article really talked more about saving time, processing time, by integrating AI with automatic measures, if you will. That study out of Norway. So again, a recurrent theme of expediting, if you will. Part of that is cardiac MR and AI. This one, again, out of Beth Israel 2024 study. Again, the whole idea is to make it more efficient, faster image acquisition hopefully better resolution, and things like eliminating the need for breath holding. And once again, hopefully integrating with other patient features, if you will, to come up with a better, diagnosis and maybe even prognosis in certain cases. Nuclear imaging, again, improving the quality of the image and shortening acquisition time, and ability to combine clinical stress and other aspects. And let me go back up to one thing I forgot to comment on: cardiac MR. I heard a talk 2 days ago from Boston Children's Hospital where they've taken this a step further, and they're considering a basically cardiac MR as a service, meaning they've created much of the pipeline. They've labeled a lot of the images and whatnot, but it's been a massive undertaking of manpower and money and grants. So I'm just commenting, they'll automate that process, but it wasn't easy, if you will. And then the third one is more of the same in a way with cardiac CT, with the idea of assisting with coronary calcium scoring, plaque quantification, and events, and also improving efficiency, if you will, and maybe combining it with urgent result notification, report generation. And this article out of Louisville also discusses some of the commercial products that are available if that's of interest. Now, I'm going to have challenges specifically for some of these. You need more high quality labeled images, meaning a human has to label this echo or EKG or whatever. And this is, believe it or not, a stumbling block. Nobody wants to label images. They generally don't get paid for it and so forth. You can use synthetic data and semi-supervised learning, which is a combination of supervised and unsupervised learning. More prospective studies, and you're going to see this as a recurrent theme, more clinical outcome studies. Actually, how did patients do? Do they fare any better? We know that AI suffers from the black box. I'm going to comment more of that on another slide. And there's some references here about more imaging protocols. Now, electrocardiography, we've already commented about some work done by the Mayo. These are two studies, one out of Italy and the Mayo, just more that confirm the fact that they did a better job. However, again, I can't quote here the number of false positives, but it was larger studies, if you will. And then in the bottom, another Mayo Clinic study that was a random controlled trial that indicated that, again, it was successful in a more diverse population. So continued studies, but no, again, too early for any outcomes. This is the Italian study. The only reason I mention it is rare for me to see a table, but notice it, once again, has area under the curve, sensitivity and specificity. Nothing else that would be important if the category of interest is in a minority, meaning the prevalence is very low, you really should report other performance metrics and not just sensitivity and specificity. So that's a recurrent theme in this review, in my opinion. So challenges: limited availability of good labeled EKGs. And I'm going to digress and say that I have had the opportunity to use this data set, which is free to use. It doesn't require city training or anything, from PhysiaNet. It came out of Germany, I believe, but my experience is it's very accurate, very clean, easy to use. And then just FYI for anybody that's got the interest in this area, there are three free convolutional neural networks you can use today. Orange Data Mining, which is what I use to teach data science, Microsoft Loeb, and Google Teachable Machine. So you can be analyzing EKGs and playing with it, if you will. Now, again, AI is a black box. We generally don't know what AI is doing. There are things called saliency maps, which help. And in one study, they used another technique called LIME, and I won't get into the details. But they were able to show in a study, for instance, that with patients with WPW syndrome, it lit up the delta wave. So that was interesting in one example where they did see. In hospital monitoring, we would hope that AI might reduce the false positive alarm rate, which is highly disturbing. Have been some randomized controlled trials that show reduced mortality rates associated with AI automated alerts. Here's a study again to point out some of the deficiencies. This was a study out of China to predict ventricular tachycardia and fibrillation. And they did publish the area under precision recall curve and F1 score. And F1 score, by the way, is the harmonic mean between positive predictive value and sensitivity. And so you look at the sensitivity and specificity, you go, not too bad, but the AUPRC and F1 score are terrible. So it really was of no value if it was mainly false positives. Challenges, lack of prospective good studies. Again, we need to look at impact with clinical endpoints. Monitor needs to be real time, but which patients will need monitoring? Everybody? We don't know, we don't have subgroups yet to know that. Also, does the average hospital have the infrastructure and financial support for what this will require to set up AI, and at what price tag? One of the things I've noticed over the years, whether you're talking about electronic health records or you're talking about anything else, the studies rarely ever quote that. You rarely ever understand what the cost is. And this article that came out of the Canadian Journal of Cardiology recently is a nice review on some of the wearables. I won't get into each one. It does go over the Apple Heart study and some, but it goes over the EKG patch, the chest sensor, smartwatch, smart ring, textile sensors. So it gives you, if you are into that, the wearables, that's an important to you. This is a good article to look at all the different ones, and you can compare and contrast, if you will. But they also have challenges. We need more and higher quality, larger prospective studies. Obviously, there's a lack of interoperability with these systems and the electronic health record if you're looking for any kind of alerts, device standardization, because different vendors do things differently. Once again, reimbursement, who's going to pay for you to look at an Apple Watch output? So that's a real issue. There is a CPT code for it, but I believe I'm right in saying it pays poorly. And here's just one other study I added to it out of the Mayo Clinic that just showed that over 90% of alerts did not lead to clinically actionable diagnosis. So you don't want something that wastes your time or the patient's time or your office staff's time. All right, it looks like we're on time and we'll have plenty of time for questions. But let me talk about AI challenges because I think that's important. What I've tried to do here, besides giving you some background, is to give you the pros and cons and not emphasize the hype. Try to emphasize the science behind it, that we know what we know currently, I should say, and try to be as objective as I know how. This is an overview. We could spend a lot of time on just one slide, but I thought this should be an overview. All right, so we'll start with the computational resources. We know that large language models like GPT-4 have huge carbon footprints. The training, which is where most of the cost is, because it takes like 6 months to train GPT-4, that's $100 to $200 million. Also, these large server farms go through like 300,000 gallons of water per day. We all worry about, privacy and security, if you will, in the training and later in the availability of these models. That's why, again, having the model on your own server is not a bad idea. We, of course, worry about bias. That's a popular term because clearly these large language models trained on what I'm calling the universe, and in there has got to be some misleading information. It may favor one ethnic group over another, for instance. The results may not be applicable to everybody. I've already addressed the fact that AI is considered a black box, but I think we'll see a time when AI describes what it's seeing. It'll tell you how it did what it did. Errors and hallucinations are a big deal. AI may not only generate incorrect facts, but incorrect references. In my large language model talk, I talk about ways to get around that. There are large language models that are way better than others for practical use, like Perplexity AI is one example I'll mention. Intellectual complacency, I do worry about, and faculty who teach worry about it. We would worry that if AI gets to be good, even better, more human-like, then people go, oh, well, AI said that this is what the CT of the head showed at 2 a.m. I'm going to trust it. And that would be an example of automation bias. Misuse potential already, you're seeing deep fake videos and whatnot. I've talked about the fact that the large language models have excellent general knowledge as a rule, but not the specific task, particularly say in medicine. And you can get around that to a certain degree with RAG, and we hope that RAG will get better. And something called fine tuning. What fine tuning means is you're actually taking a model and you're giving it lots of examples of what you want it to learn. And so that is training. Now, you can do that with a smaller model on your server. You could fine tune a model to do exactly what you want it to do. So that is an option if you have a specialized task for a large language model. Clearly, there are ethical considerations. We do worry about job loss, not for clinicians. I don't know of anybody that seriously thinks that that's going to occur anytime soon. But clearly, for administrative work, if you see tremendous efficiency gains, there's a chance of somebody losing a job. Next, cost. What is the return on investment? Will we see AI as a service where you contract for that? And what happens with these large language models when venture capital is gone? I mean, OpenAI is basically supported by Microsoft. I think Claude is supported by Amazon, so forth and so on. Are they going to have to suddenly increase their charges to you dramatically? Probably. Obviously, trust is an issue. We need better studies. I've already kind of intimated that there are not enough good studies, prospective studies, real studies. And that's where, though, I think you all come in handy. Security, again, we're already seeing a few instances of bad actors. Obviously, you need regulatory compliance. You need an a data plan for every healthcare system. Maintenance and upkeeping, how current are the models? Many of them are were trained, say, a year ago. And then one of the things that I always comment on anytime there's a new technology, what are the lawyers saying? Well, the lawyers are still trying to figure out AI and large language models. But for the board review course I teach, we're starting to see lawyers attend that. So stay tuned because there may be lawsuits that change the complexion of what we're discussing. Now, I put this together. This is just me. One of the things we teach is that if you have a research project, ideally it should impact the quintuple aim of medicine. That is, it should improve patient outcomes, improve the patient experience, improve the clinician experience, reduce cost, improve health equity. Excuse me. And that the current state I'm rating is fairly low. You all could disagree with that. You might give me either something higher or all zeros. But I do think the potential's there. I have cautious optimism that I think we'll see help from AI in medicine. And I've listed on the right some comments about what it might do. But it has to be fairly perfect when it comes to clinical decision support, even though humans are not perfect. I think we expect a great deal out of AI, and we should. And that, so I'm rating it lower, if you will, for that reason. But I will update that on a regular basis if I see something that warrants that. So my conclusions are AI seems to be needed in medicine because The amount of medical information today exceeds human comprehension. An example of that would be is up to date, I believe, is around 5,000 pages. They're looking at AI so that they can have a easier way to query the multiple chapters. For instance, if I'll use the example of lupus. Lupus affects every organ. So if you want to do an evaluation of lupus, you're going to want to look at lupus nephritis, stuff in connective tissue and so forth. So again, which is just so much information to try to comprehend. Also, if more and more now with AlphaFold 3 and other programs, if you add a genomics to the mix, now how are you going to really understand that? You need help. Again, I think one of the things that interests me more than anything else is when AI see things that I cannot see. That, what about EEGs? I mean, I think the fact that we see non-specific slowing and all that, eventually AI will probably make more sense out of it. So I think medical research would gain tremendously for it. But for the time being, clearly AI will not replace us. There has to be a human in the loop. I do think it is a game changer, but it faces tremendous challenges. But that being said, I don't think we can put our head in the sand. I think the train has left the station, as I've said. And then I think we need to be more cognizant about AI and also some of the data science basics. And I mentioned that so that we can evaluate these articles, better than what we currently do. So this, I don't know if somebody, we've already posted this. So if you're interested in CME credit, is there anything else we need to say about that?
Thank you, Dr. Hoyt. Yes, that is the code for CME credit. We can provide that in an email follow-up. We do have some questions in the chat if you were still, I think we have a few minutes for fielding those questions. We have a question from Marantha Gonzalez. Great talk. What generation of AI that can generate new or novel idea of diagnosis?
Are you asking, can any current AI generate potential diagnosis? Maybe repeat that.
Yeah, I'm not sure exactly how Ms. Gonzalez is framing that question. If you wouldn't mind reiterating what you'd like to ask Dr. Hoyt, that would be great. But I do believe that she means, is there a generation of a generative AI that can actually produce a new or novel idea or diagnosis? Currently, it's able to sift information and provide a differential, but can it actually generate new information?
I got you. And that's a very interesting and important question is can it reason? And there's disagreement about that. Right now, I would say it's limited. We'll have to wait to see what GPT-5 does, but I think it does have the potential, but I don't think we're there yet. I think in 2025, we may be able to, where it's able to synthesize something new. But right now, it doesn't. That's, again, a very important question. Does it come up with something new that's novel we have not thought about? I think the only area that I can think of is, again, expanding the differential diagnosis to include things we didn't think about. But can it put together two pieces of information and come up with a totally novel idea? I would say not currently.
Thank you, Dr. Hoyt. We have another one from TEN. With respect to the black box nature of AI that is described, once AI makes an unexpected condition, for example, sex or diabetes from a chest X-ray, can't it disclose its own process to tell us what the connection is and inform you on its process?
Yeah, the answer right now is no, but I think that'll change. I think that just keep in mind all of this is changing. There are actually now a couple of modifications of transformers like Jamba and Mamba, and even there is now a new concept of artificial neural networks. So stay tuned that I do think that eventually AI will tell you what it saw You won't have to ask it. It will report out. Either it'll give you the weights from the neural network, or there'll be some other way that it'll tell you what it saw or thought. But right now, the answer is all we have is saliency maps and Lyme, no other techniques, which would not be very satisfying to the average clinician.
He also has a follow-up question. With respect to privacy, what options do patients have to opt in or opt out of the use of their PHI?
Yeah, that's important, particularly in lieu of patient messages. There are a lot of experiments out of places like Stanford where they're using AI to screen patient portal messages. And I do think in those studies, they're all given the option to opt in and opt out because most of the studies show it does a good job, but there have been a few examples where it gave bad advice. But all of those require a patient to screen. In other words, AI looks at it, but a nurse or doctor signs off on it, if you will. So I think all those studies will require a patient a permission to opt in to have AI respond to them. But that's a very practical question. Thank you.
We have a couple of questions from Ilya Uslak. In context of using AI systems to support clinical decision making, what are the key risks or challenges associated with these systems potentially getting stuck in feedback loops, leading to over-reliance and confirmational bias?
Yeah, all of those are a concern. I mean, I've already alluded to lots of them that, they may not only give erroneous information, they may not be up to date. When were they last trained? Most of these models are about a year old, by the way. In fact, when I query them for information, they seem to be older than their training date. So that is a concern in medicine, particularly at a teaching center like MCV. You want the latest information. And I go, and I'm going to digress for a second. I use a new program called Open Evidence that comes out of MIT and Harvard. It seems to give answers that are not only accurate, but are extremely up to date with references that you can mine and suggest follow-on questions. And so I found it to be highly accurate and highly current. It is a large language model driven, although I don't know the details. But again, getting back to the question, clinical decision support with AI is simply not good enough today, and I don't know what the next generation of GPT-5 or 6 will bring to the table.
Thank you, Dr. Hoyt. His follow-up question is related to accuracy. Is it mentioned that AI models achieving around 80% performance levels are not effective enough? Can you expand on why that threshold is too low?
Yeah, well, this is interesting because I am with people that believe AI is the answer to everything, and they would say that's better than the average physician, 80%. I think it becomes a medical legal issue, if you will. Is 80% good enough? So you do have people saying that it's good enough, and you have other people saying, no, I want it to be perfect. And they can cite instances where the AI gave very bad information and use that as evidence that we're not there yet. But again, I do remind people that GPT 3.5 was introduced to everybody just 2 years ago, November 2022. That is super recent. There's a quote that says something like, if you think you understand AI, you don't understand anything. That simply means we're still in the infancy. So I think we'll have probably clinical decision support that we can trust, but there's still, I don't know of anybody that's saying right now that you take the human out of the loop. I think that the tough thing is how do you teach it to, let's say, medical students or house staff? How do you get them not to adopt it hook, line, and sinker, but to be able to look at it and think about it and say, that's helpful, but I want to look further and I will ask additional questions of AI to drill down further. So I just think 80% is not too bad. It's not too shabby, if you will. Uh, but, again, in what scenario, and also is it reproducible? I didn't put in there as a challenge, but there's some evidence that if you ask, AI for an answer 3 days in a row, you may get different answers. So that's, again, it still needs to be beta tested more. The biomedical large language models need to be published. They haven't been. That may be one of the answers to that 80%. Maybe we'll get it up to 90%. So stay tuned when MedGemini, for instance, it's being, by the way, tested at multiple universities. So let's see what that data shows. That may change all of our minds. Great question.
We have a question from Dr. Contos. Why does AI hallucinate and generate false references when asking it for information?
Yeah, there's several explanations for hallucinations. The first one is it doesn't have the answer, and so it makes something up. But there are other technical answers because it's probably, remember, I think this is amazing. It does what it does because remember, with transformers, the whole goal is just to predict the next token or word in a sentence or paragraph. Token, by the way, is when you break down a word like playground into play and ground. So it really looks at tokens, but the point is its whole goal is just to predict the next one in a sequence. How it does as well as it does, to me, is a mystery. Maybe not to a computer scientist, but to me, it's sort of magical. But the point is, that's all it's supposed to do. So there are other reasons why, because it's probabilistic, it hallucinates, and that's not a very good technical answer. But there are answers why, based on the technology, it hallucinates.
Thank you, Dr. Hoyt. Just two more questions that we have in the last remaining minutes. Follow-up question from T.N. Again, with respect to privacy, what about patients' ability to opt out of submission of their PHI, de-identified or otherwise, to large cloud-based servers, which are constantly compromised? For instance, genetic data are literally a fingerprint identifying an individual patient.
Yeah, I mean, and let me comment that it gets worse than that. If I can identify you based on your EKG and retinal image, all of a sudden now HIPAA goes, oh, there's one more. That's number 18. In other words, this is a big deal. And it's early on in the United States with HIPAA and Europe was GDPR, I think it is. It is a big issue. And we're going to see a whole new privacy challenge as a result of that, particularly if we can identify somebody by phenotypical and genotypical information augmented by AI. So I have no answer to that other than say, look for more regulation, guardrails, policy procedures on privacy across the country.
Thank you, Dr. Hoyt. And then this last question is actually from me. I think we have such a wide audience in terms of clinicians, researchers, scientists, data scientists. For people who are clinicians who don't have as much experience with AI and clinical informatics, what are some good places that they can start to get more information about how this will apply to clinical context? Because as you've said, it's not a matter of if, but when. And I do think it behooves us to be more informed and to use these techniques and these applications appropriately for our patients.
Right. And there's no simple answer. I have to say, I will announce, but I wasn't going to do it, is that I had planned to do a workshop in January on basic data science for clinicians for that reason to school them up on a lot of things. However, it's still being approved or looked at by the Department of Internal Medicine, so I can't really advertise that, but that was an effort to try to offer more help and information to those clinicians that are interested by using a program that doesn't require programming, but probably accomplishes about 90% of what they want to do. So all I can say is stay tuned. The other person that would teach this would be Aaron Montani, one of your own cardiology fellows, but I don't want to formally announce it until it's approved, but that would be my contribution to try to help with this challenge.
Great. Thank you so much, Dr. Hoyt. Really appreciated your talk, and I know so many of us enjoyed it. Thank you for your time and coming, and look forward to seeing you for potentially your workshop in January. And definitely, I'll be reaching out to Arun Matani. I think he's a fantastic co-fellow and really well known in AI.
Okay, well, my pleasure. Take care.
Take care.